Welcome to the Reimagine Healthcare podcast. I'm your host, Noah Volz. Today, we're talking about something that doesn't get discussed enough: the growing gap between how healthcare is delivered in Southern Oregon and how it's actually experienced. Not because people don't care. We have providers, clinicians, and community members who care deeply. The problem is, the system makes caring harder than it needs to be. Across Jackson and Josephine counties, patients report difficulty accessing care. Providers report burnout and overload. Communities experience growing mistrust toward medical institutions. These issues are usually discussed separately, but together they reveal something important: structural misalignment between what the healthcare system optimizes for and what people actually need. So let's break down where this divide shows up, what's causing it, and what we could do differently. Let's start with the workforce. Large portions of Southern Oregon are designated primary care health professional shortage areas. Jackson and Josephine counties average fewer than 60 primary care providers per 100,000 residents. Oregon's statewide average is 83. We're significantly below that. The result isn't just longer wait times, it's compressed visits, where providers have 15 minutes to address complex problems. It's delayed diagnoses because nobody has capacity for the follow-up that proper diagnosis requires. It's reduced continuity. You can't build a relationship with a provider you see once and then can't get back in to see for 6 months. Behavioral health, home health nursing, primary care, all strained. And when primary care is strained, everything downstream breaks. People wait until conditions escalate. They use emergency departments for primary care. Chronic diseases get managed poorly because there's no consistent provider relationship. The incentive problem: the system doesn't pay primary care well relative to specialties. Medical students graduate with massive debt and face better financial prospects in specialties than in primary care. Rural practice comes with additional challenges: professional isolation, limited resources, difficulty recruiting partners, without proportional compensation. So we get predictable shortages in exactly the areas where healthcare is already hardest to access. Geography compounds this. Specialty care remains heavily centralized in Medford and Ashland. If you live in Rogue River, Gold Hill, or Cave Junction, routine specialty visits often require 30 to 60 miles of one-way travel. Think about what that means practically. You're working an hourly job. Your shift starts at 3 p.m. The only cardiology appointment available is at 2 p.m. in Medford. You live in Cave Junction. That's an hour each way, plus the appointment. You're losing a full shift and losing income. And that's assuming you have reliable transportation. Distance quietly shapes behavior. Missed follow-ups increase. No-show rates exceed 20% in some clinics. Preventive care gets postponed until symptoms escalate, and you have no choice but to seek care. Geography becomes a clinical risk factor, not because rural residents are less motivated to take care of their health, but because the system is structured in ways that make consistent care logistically difficult. The incentive problem: specialists locate where it's profitable and convenient. Urban areas provide better infrastructure, more colleagues for consultation and coverage, amenities that make life easier. There's no financial incentive to distribute services geographically based on need. The market concentrates resources where it's most efficient for providers, not where it's most accessible for patients. Socioeconomic factors create another layer of friction. Oregon's Medicaid expansion has significantly improved insurance coverage in our region, which is genuinely important. Those middle-class residents who are not on Medicaid could be considered underinsured. With high copays and deductibles, they will often delay care because of the expense. For households dependent on seasonal or hourly work, and Southern Oregon has a lot of those, that's a meaningful barrier. Insurance coverage doesn't guarantee access when cost sharing, scheduling complexity, and transportation still determine whether care actually happens. Language and cultural barriers matter more than we admit. Southern Oregon's Spanish-speaking and tribal communities face additional friction. Fewer than half of patients with limited English proficiency consistently encounter on-site interpreter services. That's not just a soft issue about making people feel comfortable. It's a quality and efficiency issue. When care plans are misunderstood, medication instructions get followed incorrectly, follow-up doesn't happen, conditions worsen, and people end up back in the system with preventable complications. Misunderstood care increases utilization, repeat visits, and avoidable costs. The incentive problem: providing interpretation services costs money and takes time. In a fee-for-service system where you get paid per visit and visits are time-limited, slowing down to ensure understanding through an interpreter reduces throughput. So even when interpretation is available, there's systemic pressure against using it effectively. Now let's talk about trust, because this is another aspect of the divide. Trust functions like infrastructure. When it erodes, everything downstream becomes more expensive and less effective. In Southern Oregon, we're experiencing broader national trends: political polarization, institutional skepticism, inconsistent public health messaging during COVID. Research shows that individuals with conservative political views report lower baseline trust in medical institutions than their liberal counterparts. Southern Oregon skews politically mixed to conservative, particularly in rural areas. But here's what's important. Evidence from other regions suggests trust is malleable. It's not fixed. Practices like transparent clinical notes, where patients can see exactly what their provider wrote, open access to test results without having to call and wait for someone to release them, visible patient feedback mechanisms where concerns are acknowledged and addressed. These have been shown to improve trust regardless of political orientation. The incentive problem: transparency requires cultural shift and sometimes system redesign. It's easier to maintain traditional hierarchies where information flows one direction and patients are told what they need to know. Opening access to notes means providers have to write differently, knowing patients will read what they write. That takes time to adapt to. Patient feedback mechanisms require staff to respond, which takes time and emotional labor. So even though transparency builds trust, there's friction against implementing it. So we've identified the problems: workforce shortages, geographic barriers, socioeconomic friction, language and cultural gaps, eroding trust. What's actually working to bridge these divides? What could we do more of? Telehealth, when used well, functions as network glue. Telehealth programs connecting rural clinicians with urban specialists have reduced patient travel and wait times by up to 35% in pilot settings. But here's the key. It works best not as a replacement for in-person care, but as connective tissue between under-resourced and well-resourced settings. E-consults where a primary care doctor can quickly get specialist input without requiring the patient to travel for a full appointment. Remote monitoring where patients manage chronic conditions at home with specialist oversight. Behavioral health integration where rural clinics can access psychiatric consultation. The problem: reimbursement for provider-to-provider e-consults remains inconsistent. Insurance might cover a patient telehealth visit, but they won't necessarily cover the time a specialist spends consulting with the primary care doctor, about how to manage a patient's complex case. So providers do it anyway because it's good care, but they're not being paid for it. That's not sustainable at scale. Community health centers like Rogue Community Health and La Clinica are doing something really important. They function as more than clinics, they're patient navigation hubs, sliding scale care based on income, integrated behavioral health so mental and physical health get addressed together, on-site interpretation so language isn't a barrier, community health workers who manage referrals, help with insurance enrollment, coordinate follow-up. These models reduce friction across the care journey, not by adding disconnected services, but by coordinating them. You're not navigating 5 separate systems. You're working with one team that helps you access everything you need. What makes this work is intentional structure. These organizations have chosen models that prioritize access and navigation, even though that's not what gets reimbursed best. They've found funding through federal programs for community health centers, through grants, through coordinated care organizations that recognize the value of this work. But it requires constant advocacy to sustain. Workforce incentives exist but aren't being fully utilized. OHSU's Healthcare Provider Loan Repayment Program offers up to $60,000 in forgiveness for providers who practice in underserved areas. That's significant money. But participation in Southern Oregon remains lower than it could be. This points to a common systems failure. Program availability without local alignment. Recruitment improves not just with financial incentives, but with community integration, mentorship, sustainable workloads, and quality of life. If you're offering loan repayment, but the job involves seeing 30 patients a day with no support staff in a clinic that's falling apart, people won't stay. So what could we do differently? What are the strategic levers worth pulling? Permanently reimburse e-consults to integrate rural and specialty care. Right now, it's inconsistent and often depends on temporary pilot funding. Make it standard. Pay specialists for the time they spend consulting with primary care providers. That reduces unnecessary specialty visits, improves rural provider confidence, and keeps patients closer to home. Strengthen community health worker and patient navigation programs. These reduce no-shows and care drop-off dramatically. When someone helps you understand your diagnosis, schedule your appointments, figure out transportation, and follow through on the care plan, outcomes improve. Fund this work systematically rather than depending on organizations to cobble together grant funding. Tie workforce incentives to local onboarding and retention, not just placement. Build mentorship programs, create sustainable panel sizes, provide administrative support so providers can actually focus on patient care. Measure success by how many providers are still here in 5 years, not how many you recruited this year. Require ongoing cultural competence and language access training. If you're practicing medicine in a region with significant Spanish-speaking and tribal populations, you should have basic cultural competency and understand how to work effectively with interpreters. That's baseline quality care. Normalize transparency tools that rebuild trust through visibility, not persuasion. Give patients access to their clinical notes. Make test results available immediately. Create feedback mechanisms where patients can voice concerns and see responses. This doesn't require persuading people to trust institutions. It builds trust through demonstrated accountability. Here's what Reimagine Healthcare is working toward. We're not trying to create entirely new systems. We're trying to help existing pieces work together better and advocate for the structural changes that make good care sustainable. That means connecting employers with information about how their benefit design affects whether employees can actually access care. Supporting enrollment outreach for Oregon Health Plan. Highlighting organizations like Rogue Community Health and La Clinica that are already doing integrated, accessible care well. Advocating for telehealth reimbursement and community health worker funding. We're also working to document what's happening locally. When people can't access care, we want to understand why. Is it cost, geography, language, trust? Different problems require different solutions, and right now, we don't have good local data on where the specific barriers are. The patient-provider divide in Southern Oregon isn't a failure of compassion. Providers care. Patients want good care. The failure is structural. Systems designed around incentives that don't align with access, continuity, or trust. When care is distant, rushed, linguistically mismatched, or financially opaque, trust erodes and utilization becomes inefficient. People avoid care until they're in crisis. They don't follow through on treatment plans they don't understand. They use expensive emergency services for preventable conditions. Conversely, when systems are designed around navigation, continuity, and transparency, outcomes improve without necessarily increasing spending. People get care earlier. They manage chronic conditions better. They trust the system enough to engage with it. Healthcare in Southern Oregon doesn't need to be reinvented. It needs to be reconnected across geography, culture, incentives, and expectations. Bridging the divide isn't about asking people to care more. Providers are already working harder than is sustainable. Patients are already doing their best to navigate a complex system. It's about building systems that make caring sustainable. Systems where primary care providers have manageable panel sizes and adequate support, where geography doesn't determine whether you can access specialty care, where language isn't a barrier, where transparency builds trust rather than requiring persuasion, where community health workers bridge the gaps that clinical care alone can't address. That's the work ahead. Not sweeping transformation, but intentional realignment. Getting the pieces we already have to function as a connected system rather than as isolated services people navigate alone. Before we wrap up, the usual disclaimer. This podcast is for educational purposes only. It's not medical advice. If you're navigating healthcare challenges, work with your providers to figure out what's right for your situation. Also, I might get details wrong. If you catch errors or have additional perspective, please comment or contact me directly. That makes all of this better. If these conversations are valuable to you, subscribe to our newsletter at reimagine-healthcare.org. That's where we go deeper on local healthcare issues and build community around making Southern Oregon's healthcare system work for the people who live here. Thanks for listening.